Assalamu alaikum and welcome, dear physicians. Today we have 82nd lecture session organized by ECG study group, ECG Basic and Beyond. Today we have lecture 2 of session 1, that is wide complex tachycardia, ventricular tachycardia versus supraventricular tachycardia. It will be provided by our very renowned Professor Rafique Ahmed sir. As usual, before the start of the lecture, I'd like to request Professor Atahar Ali sir to say something about the topic and about our Rafique Ahmed sir, and then we proceed. Atahar Ali sir.
Good evening and good morning, actually, dear participants. Dr. Rafique Ahmed sir actually does not need any introduction in this forum, but we always very much feel proud to introduce him as the founder of electrophysiology in this country, in Bangladesh, and still his job is not terminated. Actually, he's doing a lot every day, every time, that is for the development of electrophysiology and related subjects in this country. We are very much feel too proud to introduce him as the founder of electrophysiology in this country. And he's the actually world-renowned electrophysiologist. And this topic today, really, I don't know, and it is a really well-discussed topic, and actually it has no end, but this is a very difficult topic to all ECG learners and for everybody. So I think this is the real topic, and Rafique sir is the real person to discuss these topics, SVT versus VT. I think the participant will enjoy these topics. Rafique Ahmed sir.
Assalamu alaikum. Good evening and good morning in States. So this topic we have discussed many times, and the whole point is that we keep repeating the same topic so that we refresh our memory. I made a little new twist on this. So I need some poll. So this is one patient with non-ischemic dilated cardiomyopathy, came with shortness of breath and palpitation, and this is the ECG. As you can see, the heart rate is about 200 beats per minute. So can you give a poll, please?
Kamrul bhai, please give a poll. Sir, Kamrul? Kamrul bhai, have you given the poll? Okay. Sir, we'll keep the ECG for 30 seconds.
Yes.
Okay.
Okay. So majority said ventricular tachycardia. And so I like comment from the faculty. What do you think? Hafiz Ahsan.
I think I can try to comment on that. It looks like that, pretty, it's wide complex tachycardia mainly.
Mm-hmm.
And if you can look at that, whether you see any, how the axis looks like, okay? Mm-hmm. Look at the axis here, and also try to find out if you see any AV dissociation information, whether any P wave anywhere. And if you look at that.
So what do you think, Haji? This is VT or SVT?
It's likely VT.
Okay. Wadud?
Sir, the thing is, it could not be sinus tachycardia because the rate is too high.
Okay. That is correct. Yeah.
And it's wide complex tachycardia, all right. But the point is, could it be either with atrial flutter with underlying LVPP or not? The axis in ATR is positive, so that goes in favor of ventricular tachycardia.
Okay. Yeah.
But I was actually looking for AV dissociation, which could have given me the chance to say confidently that it's really VT.
Sure. Okay.
I am not getting that.
Sure. So, I mean, this patient has all the substrate for ventricular, has non-ischemic cardiomyopathy, a white QRS tachycardia, which you cannot. And the reason I put this ECG is to put out a point that how difficult it can be. Look at the same patient when the rate slows down. Exactly same morphology. So it was left bundle branch block, very wide QRS, and it's a diseased heart. So you see, this is now you can see one flutter wave, second one.
This 2:1 flutter, yeah.
It was 1:1, but there is no way that one can confidently say from this ECG anything other than ventricular tachycardia. So if this patient came to me, I will first instance, I would think this is ventricular tachycardia. And so even with all the discussion that we do, we will have cases like this. Now, so this is the one, another one. Again, I would like poll. I will keep the ECG for 30 seconds and then put up the poll, please.
Sir.
Yeah.
Sir, can we back to the first ECG again, sir?
Yeah.
Sir, this is actually if we apply the Brugger algorithm, sir, actually
Yes.
there is concordance. This V1 to V6 there is no concordance. There is the V6 is positive,
Yes.
but R2S, sir.
Yes.
How to calculate the R2S from this ECG? That what will be the?
We'll come there. R2S is normal actually.
Sir,
It's not 100 milliseconds.
yes, sir. Sir, in V1, if we magnify the V1,
Yes.
it clearly shows that it is not more than 80 millisecond, in fact.
Yes.
If we magnify the V1.
Yes, that's true. So those are the favors. But when you have this ECG in front of you, you remember, Tushar, last week you mentioned something that, look, when the patient is sick and have this ECG, if my student says this is ventricular tachycardia, I have to give him yes answer. I mean,
Particularly in the background of the non-ischemic cardiomyopathy.
yes, but you are absolutely right. If you look at the beginning of the QRS to the deepest point of S wave, it's not over 100 millisecond, not even 60 millisecond. So that favors, because initial part. So no question, yes. Atahar, any other comment?
No, sir. Actually, I was confused about this point. Otherwise, this is widely wide. More points are in favor of the VT, sir. Actually, widely wide. Then LBB morphology.
Yes.
Then extreme non-axis deviation, that is AVR is positive. So most of the points are in favor of the. So I think this was a very important point. That is R2S.
Yes.
And also I'd like to make another point. Look at the amplitude of the QS. It's varying a little bit.
Yeah. Okay. So this was the one. So the previous ECG, having an old ECG, brings up the point that when you have a white QRS tachycardia, if we can pull up an old ECG on the same patient, that will help us in the diagnosis and differentiating between SVT with bundle branch block versus ventricular tachycardia. So, poll, please. So we have everything here. Wadud.
Sir, the confusion is created by your previous talk, sir, because the rate is so high. So some people go with, because the rate is atrial flutter with RBBP, which is, I think, is valid to some extent. Again, when you see that extreme axis deviation, then some people will go with one, ventricular tachycardia. But the narrowness of the initial part in the V5, V6,
Mm.
I think that goes in favor of SVT with RBBP.
I think I agree with Dr. Wadud. Because I can
Yeah.
also see clear-cut retrograde P wave at the each end of the QRS.
That's
If you
in
look at
lead one.
3.
Yeah, the retrograde P wave part, the problem is, if we look at lead 1, is it retrograde P wave or part of QRS complex? Sometimes it becomes so difficult. But one point is true. First of all, I would like to have an old ECG on this patient.
Yes.
Second, Wadud's point that made, I'm going to come to this point, that this, if you look at V5 and V6, if you ignore everything, it looks like a normal R wave. And I'm going to come to that. So wide distribution of choices here. Atrial flutter with right bundle branch block is a possibility, but it will have to be a very slow flutter. Sinus tachycardia with underlying right bundle branch block is very difficult to go to a sinus tachycardia at a rate of 219 beats per minute. One thing look at in V1, there is a small R followed by big R. That favors right bundle aberration with supraventricular tachycardia. And Wadud's point, the initial part, even though we don't use this algorithm, but it's the important part to remember. Now, look at this. Same patient, when they convert to sinus rhythm, exactly same ECG. So again, to make the point, quickly getting if there is confusion, getting an ECG, old ECG, makes it very, very easy for us to differentiate.
Sir, again back to previous ECG, sir.
Yeah.
Sir, if we apply the Brugada algorithm, there are many points in favor of the VT, sir.
Okay.
Sir, as because, sir, what we call, there is a concordance pattern is not applicable here as because there is R and S both in the V1 to V6.
Yes.
So this point is not applicable. R2S, I think, R2S, this is also borderline, I think, sir. Here, R2S. Then if we go to the morphology pattern, sir, that is the most important part, the morphology pattern, that is RBB morphology. Sir, what we call that is the V1, whether it is monophasic or triphasic, as because V5 R is smaller than S, it is again in favor of the VT. And
Yes.
if we call the V1 is monophasic, this is again in favor of the VT.
Yes, if we call the monophasic, it is. You see, R to S will not apply because that applies only with left bundle morphology, not with others, most of the time.
Sir,
And the other part is that you don't know whether this is, whether this is part of the QRS. It probably is part of the QRS complex. Go ahead.
sir, in V1, if we follow the old teaching from Shamroth, that rabbit ear, if we consider the V1 rabbit ear, the left one is the smaller and the right one is the larger, which goes in favor of SVT with aberrancy, which the old teaching, sir. I don't know whether it applies, still applied or not.
But
It
what
is
is that?
true.
What is
It
the
is-
pattern in V1? V1, Tushar?
Yes, sir, V1.
Yes, it is true. But what Atahar is saying, even though there is 2R, it almost looks like monophasic. That is the confusion with this patient. So and there is a reason I put this ECG, and that's the reason that V1 doesn't look very typical right bundle. But when we bring up the old ECG, look at it, looks almost similar. It doesn't, this S wave doesn't go below. Let me see. This S wave doesn't go below the line. So this is another example. Now, this is the difficult one. That this is one of our patients came to the emergency room with palpitation. We don't know much about this patient. Patient is 38-year-old male, palpitation, blood pressure is 110/70, adenosine converted to sinus, and then developed tachycardia. Adenosine converted, didn't convert, and then diltiazem converts to sinus rhythm. What is this one? We'll have a poll, yeah.
Sir, I think you have already given the hint.
Well, let's wait. Let's see what our participants say.
Sir, in the meantime, in case of regular tachycardia, wide or narrow? How much you appreciate use of adenosine in hemodynamic stable patients?
We'll talk about it in a second. Let them answer and then we'll discuss it. SVT with right bundle, ventricular tachycardia, atrial flutter, nobody said that's good news, because if it is atrial flutter, it's too slow 1-to-1 or too fast 2-to-1. Sinus tachycardia with right bundle, possibility, but to go to a rate of 197, that has to be a very sick patient. So I think anytime you see a heart rate of 197, somebody just with palpitation and blood pressure normal, it's unlikely. So I think we should take that off. Don't you think so, Wadud?
Sir, I agree.
Yeah. So our confusion was...
But my confusion is, sir, look at the QRS complex in the rhythm stream in V5.
Yeah,
some complexes are bigger, some is well, electrical alternates like thing.
Yes, yes. And of course, there is the RWave. We'll come to that. So the whole point is that it stopped with adenosine to sinus rhythm. Adenosine did atrial diaphragm. Now, of course, the use of adenosine is helpful, but not always true. Because if you have fascicular VT, that can respond to adenosine or calcium channel blocker with delta IgM. So, and then I'm going to bring second ECG on this patient to make it a little bit more interesting. So this is the patient sinus rhythm ECG. And we did echo, EF 55 to 60%, no wall motion abnormality. Cardiac MRI was no scar, fibrosis, or infiltrate. And this is the ECG during sinus rhythm. Now, let me see. So this is, again, this is one place where we could, patient was in sinus rhythm and then converts into the tachycardia. So please carefully look at it. Look at bit by bit. Faculty, any comment? So this was a very perfect case because I could get this ECG when it converts, it changes into the tachycardia.
But there is no morphology changes, sir. I mean,
there is no morphology change. So now I'm going to come back again to the pole. So let's see what the pole now is. Can you put the pole? Now, majority says supraventricular tachycardia, 3 still says ventricular tachycardia, sinus tachycardia flutter. Okay, so, and our initial clinical impression was it was supraventricular tachycardia with underlying bundle branch block. So we sent the patient for electrophysiology study. And this is the tachycardia that was induced. And this is the intracardiac recording. Look at this. This is where the tachycardia starts. The first beat that is conducted, but then there is AV dissociation. So this was ventricular tachycardia. So it tells you that even with lot of discussion, and then I looked back, if I look at lead V1, 2, 3, all of them look similar. But only subtle change that I found that in V5, look at the R wave is bigger, R wave gets a little smaller, and V6. But that's such a subtle change, there was no way of differentiating this. So in my initial clinical diagnosis, when I referred for electrophysiology and ablation was supraventricular tachycardia, it ended up being a ventricular tachycardia. It was a fascicular VT. So we initially,
Sir, if we go back
Yeah.
to the ECG, sir, the initiating, sir, the ECG,
Yeah.
yes, sir.
Yeah.
Just before the
R1T,
tachycardia
R1T,
started,
look at this.
no, sir,
Yeah.
just before the tachycardia started, the PR is much prolonged than the PR before. PR is more prolonged in that group. So that
No,
Yes.
Tushar, I don't think so. The second and third QRS complex has same PR interval, but the fourth one that comes over the T wave, ectopic.
I think, sir, one of the more important point, there is a AB dissociation is there. That is the hallmark of VT, I think, sir.
But that we just say, unfortunately, on the surface ECG, we cannot see it. It is impossible, but only intracardiac showed it. So clearly, no question this was VT, but the reason I'm bringing it up, the difference is so subtle. If you look at V2, look at the R wave changes. In V2, R wave is bigger and small, and then bigger, small and bigger. So it's a very, very subtle change. And the whole point of bringing up this ECG is to show that we have to keep an open mind when we look at this ECG and we discuss it. So I'm going to move on. What is this one? I always like to make sure that we are doing a good job of what we have been doing for such a long time, and I would like a poll on this. Poll, please. Did you put the poll? Tushar? Can anybody hear me? Okay. Okay. I'm sure whoever chose number C and D just did it random choice, because I just put it as a wild guess. It cannot be atrial flutter, because you can see P wave QRS complex, P wave QRS complex. And there's ectopic atrial rhythm. P wave is upright in lead 2-3 AVF and negative in AVR, biphasic in V1. This is clearly sinus rhythm, so this is not ectopic atrial. This is normal sinus rhythm. Question is whether you use non-specific ST T wave change. That's debatable, because there is some flat T wave in AVF and negative in 3 doesn't really count. I think it was a normal ECG. Thank you. So the reason I put this, I would just want to look at the conduction. How does it happen, the QRS complex? So when the electricity comes down through the conduction system, the septum is initially activated from left to right, and it produces a small R wave in lead V1. And it is less than 40 milliseconds, actually less than 30 milliseconds. And because it is moving away, in V6, you may see a Q wave, small q, which is not always true. And then the electricity moves down both the left bundle and the right bundle. And you see the right ventricle is small, so it predominantly records the left-sided signal, and that's why in lead V1, you get a negative complex, in V6, get a positive one. And that's what Wadud was talking about, that when there is a normal activation through the left bundle, you get a narrow initial R wave. And then, of course, you depolarization, and then you get the QRS complex. So what happens with bundlement block? The reason I'm bringing this up, I want to look at the conduction system first. So this is, again, please put the poll up. These are simple ECGs. I just want a quick response from the audience. Don't think too much on these ECGs. Okay. It's interesting. One person said left bundlement block, right bundlement block with non-specific, with left atrial enlargement and right bundlement block. Okay. What are the first? I'm having a little difficulty. Sorry. Normal ECG has Wadud, please. Wadud is there? Tushar?
Sir, I'm here.
Okay, what do you think? I mean, people answer sinus rhythm normal ECG.
I'm
Go ahead.
hello. Sir,
Yeah.
we are seeing your name again, but no ECG now.
The screen.
Oh, so I'm going to unshare. Oh, resume. Something happened. Okay. Can you see it now?
No, sir.
Yet not.
Not yet, sir.
Yes, sir.
Okay.
right.
Yes. Now is
I'm going to do it again. Can you see it now?
Yes, sir. Right, sir.
yes, sir. Yes,
Okay.
sir. Right now.
Okay.
You know, sir,
So-
what I tell the students during interpretation ECG, make lots of mistakes. Don't worry about it, because we also make mistakes. But what is important, from each mistake, you try to find out why you have made that mistake. And that will point you to the right direction.
So first of all, the QRS duration is not normal. So you cannot be normal ECG. Sinus rhythm part is correct. Second, whether it's right or left bundle, M pattern in lead V1 and RS pattern wide S in lead V6, that's right bundle, not left bundle. So please be clear about it. Whether you choose possible left enlargement or right bundlement block, just be 3 and 4, both are equal choices. I thought that there is a little bit deep terminal P wave, and maybe there is right bundle with left atrial enlargement. Okay, so how does it happen? So again, if the right bundle is blocked, just like in normal ECG, initial activation will be from left to right, and there will be a small R wave. What happens next? Next part is just like usual. We have left-sided activation. Right bundle was blocked, but even when right bundle conducts, it is not recorded by the ECG machine because predominant signal is the left. And that's where Wadud's point comes, that in right bundle in V6, initial R wave will almost look normal. And then once the left is activated, you have now activation through the muscle. And it takes a little bit longer time, it's slower. And that's why you have a terminal S wave in V6 and a wide R wave in V1. And that's how right bundle happens. And then ultimately you can see the complete ECG. So how about this one? Please put up a quick poll. Okay. So I think we need to do some work. So again, if we look at the QRS, it is wide. It cannot be normal ECG. And then of course, we can choose the all three. But just right now, we discussed that to have a right bundle, you have an M pattern, RSR in V1 and tall R and deep S in V6. So right bundle is out. And then question is sinus rhythm with left bundle bench block, sinus rhythm left bundle with possible lateral ischemia. In the presence of left bundle, this T wave change is normal. And so it doesn't count. So this is sinus rhythm with left bundle bench block. Now, the next one. Any comment? How about this one? Little different ECG from the other one. That this one doesn't have an R wave in lead V1. Otherwise, it's almost similar. Poll, please. Okay, so that's good answer. Nobody answered normal. That's good news. One person said right bundle bench block, which it is not again, because right bundle will have an M pattern in lead V1 and RS pattern in V6. And then this is the part that we always grapple with it, that is it left bundle with septal infarct or is it just left bundle? And Wadud, any comment? Or Atahar? Or Ajit?
Sir, can I make a comment, sir?
Yes.
Whenever we are looking for ischemia in the presence of LVVP, look at is there is any discordance between the T wave and the QRS complex. What do we expect? In case of LV, left bundle branch block, the left ventricular leads, that is 1 FL56, will have a T wave that's opposite to the QRS complex. If it is on the same side, upright T wave, that means there is primarily an event that is increasing the current of that part, repolarization, and that's likely to be ischemia. Here we are getting what is expected. That goes in favor that is only pure LVVP.
Yes, but the question is not acute ischemia, Wadud. Is it old septal MI? Because there is no R wave in V1.
Sir, possibly not.
Again, sir, if there was a notch in the upslope of the QRS complex in the V1, V2, V3, that would have suggested a scar in there that goes in favor of infarction. And it's a smooth transition that goes in favor, it's a pure LVVP.
Sure. So this is always the problem that we face. Is it septal infarct or is it not? So let's look at how left bundle is produced. So this is one left bundle bench block. The block is at this level. So the initial activation will go from left to right, will produce a small R wave in lead V1, and there will be a R wave in here. There is no, why isn't there is a Q wave? It's because there is simultaneous activation from this way, and in other side, sometimes we get activation left to right. They neutralize each other, and we get a positive one. And then, because it is set from right bundle, it activates the left side, we get a deep negative S wave. And this conduction is fast because it is coming down through these pathways. It goes faster. And then we get this, and then finally, we get this ECG. But remember where the block is. However, if the block is higher up, there is no left to right activation. It's only right to left. And that's how in lead V1, we sometimes end up with this lack of R wave with left bundle. And this has been actually studied extensively. I found a paper, they have gone inside and looked at where the block is. And the reason they studied is when they want to do his bundle pace, left bundle pacing, if they pace above the block, it will not work. You have to pace below the block. And that's why this study was done. And then if once the activation, then it activates from just like rest of the left bundle branch block. And you end up with, so you get this septal Q pattern, but this is not a septal MI. So I just remember this thing. And then I put the normal ECG on the top just as a comparison. So why am I showing this? I'm showing this thing because when we talk about wide QRS, bundle branch block produces wide QRS, but that's a relatively partly activated through the conduction system, partly through the myocardium. But let's say if I get a ventricular tachycardia from here, that will not use the conduction, it will be really wide. And if it comes from the left side, it will produce a right bundle morphology in lead V1. If it comes from the right side, it will produce left bundle morphology. And there is extensive study on it, and it can produce different kind of morphology. But I'm going to put this ECG now. And I would like, please look at this ECG, and then we'll put the follow-up. Okay, so we have answers: sinus tachycardia with underlying right bundle branch block. And then we have atrial flutter with left bundle branch block and sinus tachycardia with hyperkalemia. I'm going to start with sinus tachycardia with hyperkalemia. This rate is very fast. It's about 210 beats per minute. And hyperkalemia will produce really bizarre QRS complex. This looks bizarre, but if you look at these signals are fairly sharp. So it is not sinusoidal. Sinus tachycardia with underlying right bundle branch block, yes, it's a possibility because in lead V1, there is a tall R wave. Atrial flutter with left bundle branch block will not apply because look at V1, there is no small RS. Of course, if you look at V6, it looks like left bundle. One thing is true, that all the QRS complex in chest lead is positive. And that we call concordance. It's positive concordance. And if we find concordance, it is more or less 100% is ventricular tachycardia. And I will tell you why. Any faculty, any comment on this?
Sir,
Yeah.
Sir, if you can zoom the V1, is the hump following QRS indicates the atrial activity or VA dissociation?
Oh, yeah, yes, it's a possibility. But you know, this we have to be. You are talking about this hump. This hump,
Yes,
maybe. But we have to go beyond that. Wadud or Atahar, any comment?
Concordance means one thing. It's not following the usual conduction system. You would have the changed QRS complex morphology when it goes through the normal conduction system. If it doesn't, if it goes from one focus and is spreading all over of the heart from there, that will produce a uniform morphology of the QRS. And that goes in favor of VT.
Exactly. So, you know, we discussed bundle branch block that it goes through the conduction system and there will be different shapes of the QRS complex. But to produce single morphology, you have to come from one focus and the electricity is going towards all the electrodes. There are two, somebody raised hand. And can you see if somebody wants to ask a question from the audience?
Dr. Ajay Dotto, he raised hand.
Okay.
Kamal bhai, can you please make?
Hello, sir.
Ajoy,
Sir, I want to know the mechanism of IVCD. We frequently found that some QRS morphology not fitted with both
yes.
RBB or LV pattern. What is the IVCD? What is the mechanism behind this?
The question is, how do you get non-specific interventricular? I mean, I don't think anybody has studied it, but if you slow down conduction in through the bundle branches, you will get non-specific change in the QRS, but I don't think anybody will be able to give a definitive answer on that. So what I did, I took these ECGs and I superimposed on the heart. So look at this. This ECG, I have taken V1, V2, V3, V4, V5, V6. All of them are positive. And if what Wadud mentioned, it must be coming from one point. And only point possible is that if the ECG, the electrical impulse is coming from here, which is the left lateral wall of the left ventricle, then it will go towards all these electors. And that can never be an aberrant conduction. And if that is right, so this is what I'm talking about, that if this is the focus, then this signal will go towards V1, V2, V3, V4, V5, V6 and produce. And if that is true, then 1 and AVL should be negative and 2, 3 AVF should be positive. And then I have superimposed those ECGs also. Look at this, lead 1, lead AVL, negative. That means moving away from this and is moving towards 2, 3 AVF and it's positive. So just concordance, the reason I made this, it took me a little time to make this from this patient's ECG. And I wanted to have some concept that don't try to memorize things. Just think about it, the concept that Wadud just mentioned. And this similar thing can happen that if it is an apical VT and it is moving away from all these electrodes, then it can be negative concordance. If you find that, that means it is clearly ventricular tachycardia. Any comment, anybody else? So if we find precordial concordance, that means QRS or monophasic R, but no RS pattern, then it's ventricular tachycardia. Next would be, if we look at this ECG, what do you think is this? Let's put a poll up. Okay. So a majority said sinus tachycardia with left bundle branch block. I mean, it's a possibility. And then ventricular tachycardia. So rate is little bit, and that's the reason for putting this. Rate is about 150 beats per minute. Yes, it can be sinus tachycardia. If it are left bundle branch block, you don't expect a negative in lead 1. But let's focus on the chest leads. What does it have? If we look at the chest lead, look at the V1 and V2. Remember that when I discussed the left bundle branch block, the initial R was very narrow. And this intrinsic, this initial deflection was very sharp, which it is not. So we look at a criteria called onset of R wave to the deepest point of S more than 100 milliseconds in any precordial lead. And if we do this in this ECG, if you look from the beginning to the deepest point of S wave, let me see if I magnified lead V4, and you can see in lead V4, it is 1, 2, 3 boxes, a little bit over 3 boxes is about 130 milliseconds. So if from the beginning of the QRS complex to the deepest point of S wave, any lead is more than 100 milliseconds, SVT, because it's taking a long time. And the whole point is that the activation is not going through the normal conduction system. So VT is the diagnosis. Now, how about this one? We want few more answers. Only 6 people answered, as opposed to 11 last time. All right. So majority said sinus tachycardia with underlying right bundle branch block. One person said ventricular tachycardia, and then 2 persons said atrial flutter.
I feel this is junctional with underlying RBBB.
Okay. Sure. So we will come to that. Question is, how do we do this?
But the rhythm shows some PF decision.
Yes. So this is the point as to Wadud is bringing up, that look at the rhythm stream. So I'm going to go to a different ECG. If remember that I showed this ECG before, that when we induced ventricular tachycardia in this patient, these are the QRS complexes, ventricular tachycardia, but you can see the P wave marching independently of QRS. And that's more common in VT. And of course, sometimes we can see it and sometimes we can't. Like if you look at this P wave, it is buried in the QRS, this one is buried, this one is buried, so you cannot see it. But this is ECG. That is something. If you look at lead 2, something here which is not present here, not present here, not present here, but present here. It has to be present all the time. See, now not present, but there is something here. So if I look at this,
VT.
Is there AV dissociation? This patient has P wave. Intermittently, no relation to the QRS complex. So there is AV dissociation. And there are other features. Now, if we're talking about right bundle, if you look at this, we'll come to that morphology pattern later on. But this time, I'm just trying to focus on this AV. So if there is AV dissociation, then it's ventricular tachycardia. If it is junctional tachycardia, the reason you will not see AV dissociation junctional tachycardia, there will be some retrograde because it is coming from the junction. It will go backward into the AV node, so, to the atrium, and come down to the sinus. And there will be one-to-one retrograde conduction. Very rarely you can see junctional tachycardia with retrograde block. It is very, very uncommon. It is not impossible, but it is uncommon for this to happen. So if there is a video, that's more. All these criteria, if you find these are more or less 100% comfortable in describing them as ventricular tachycardia. Now, there is another feature that you can see. You see, there is a AV dissociation, but if you look at this QRS complex, and this one is a little different. That means this P wave conducted and fueled with the ventricular beat and produced something called fusion beat. Presence of fusion beat, or if you see a completely normal looking QRS during a white QRS tachycardia, then that's ventricular tachycardia because that's a capture beat or this is fusion beat. Now, the problem is that this is a relatively slow VT, and that's why I could see it. When the tachycardia gets fast, it is unlikely that you will find a capture beat or fusion beat. This was a patient of mine in Georgia My rate was, look at this rate is about 100 beats per, very slow VT. So, yep, let's look at this one. Okay, sinus tachycardia with right bundle branch block, and then sinus tachycardia with right bundle also. Those are the majority, and only one person said ventricular tachycardia. Yes, it's a possibility that this is right bundle with septal infarct. However, if you look at lead V6, look at the terminal S wave. It is a sharp signal. It is not. And then in lead 1, you don't see R and S pattern that we see in the left, in right bundle branch block. And I'm going to come to this, to this ECG later on.
Sir?
Yeah.
Sir, the previous ECG?
Yeah.
Sir,
Go ahead.
is there anything spike like something, sir? There is something like spikes before the QRS.
In which lead? Oh, in lead
In
V2?
V2.
Yes,
In
it
V2.
looks like spike. But if you look at lead V3, it's the signal that's picking up. It's part of that QRS complex. So this is not a pacing spike. And I'll show you, I have intracardiac on this same patient. So, but clearly it looks like a spike, but it's then you look at, is there any other signal, simultaneous lead, what's going on? And you can see that lead V3, there is a little hump, and that's probably part of that being recorded by the machine.
Obviously.
Next one, this one. The rate is 165 beats per minute. Paul, please. Okay, more answer. We have sinus tachycardia with the right bundle branch block majority, but look at the V1. In typical right bundle, initial R will be smaller, second R will be bigger. If it is reversed, it is more likely ventricular tachycardia. And look at V6. There is a small R and S. Atrial flutter with underlying right bundle branch block. I mean, those are the possibilities, but let's go to the next slide. So we use morphology criteria. And is there any morphology criteria? So look at this morphology criteria. This is that we use is in right bundle ECG, if there is a QR pattern or monophasic R wave or RS pattern in V1 and small r deep S in V6, those suggest VT. So if we bring this patient, if you look at this is monophasic R wave. That means, and then small r deep S. Based on both criteria, this is ventricular tachycardia. So it fulfills this criteria. Look at this criteria. Ratio of R to S is less than 1. So this is ventricular tachycardia. And this patient fulfilled what Atahar was mentioning, that from beginning of R wave to the deepest point of S wave is more than 100 milliseconds. Also look at lead V1. It's a QR pattern in lead V1.
Yes.
This is ventricular tachycardia. It's a very slow VT. we also confused with this patient because this patient was very stable. This is a patient with cardiomyopathy ICD. And so what we did is that we got intracardiac signals. And so this is the atrial channel. You can see this is atrial P wave marching independently of the ventricular channel. So when you look at this ECG, the way we try to improve our knowledge is that you come up with a diagnosis and then you try to prove it. You just don't, I cannot put up a slide in front of you and not knowing, not confirming that this is VT. So you can see from the intracardiac, and this rate was so slow that the defibrillator did not deliver therapy, because if we program to 103 beats per minute, the patient would end up with a lot of defibrillator shock. And these are relatively narrow QRS, and we were wondering whether it was fascicular VT or not. And a lot of patients with ischemic cardiomyopathy can have fascicular VT. Both of those VTs are relatively narrow. That's why all of you confused with right bundle and supraventricular tachycardia. So,
sir, can we go back to the original ECG?
This one?
Yes, sir. Here in AVR, the QRS complex is positive, and there is clear-cut AV dissociation.
Yes, yes, there is one. Yes, absolutely. You can see that one bit there.
And then also that whenever we get QR in V1, that goes in favor of VT, isn't it, sir?
Yes, and that is the other ECG. Give me 1 second. This is the one that you are talking about. Yes, this one. And also the QR, I mean, if you think of that it is right bundle, somebody develops septal MI, the second R wave will be wider, not that sharp. And look at V6 also. The terminal S wave is not wide as in right bundle. So QR suggestive of VT. What is any other comment? So this is left bundle type. If you look at, and in the left bundle type, we look at something. The initial R wave, if it is more than 30 milliseconds, look at this initial R wave. It is more than 30 milliseconds. And then we look at V6 and also look at beginning of the, in lead V1, beginning to the deepest point, is here, it's 100 milliseconds. Anything more than 60 milliseconds, it is slurring of the this initial segment, that's VT. And then if you look at, of course, this also fulfills the criteria that beginning of the QRS to the deepest point of it, so more than 100 milliseconds, this is 130 milliseconds, this is VT. So if we look at this one, this is, if you look at the, it doesn't fulfill any of those criteria, even though it looks like left bundle, it's a funny looking tachycardia, but beginning of the QRS to the deepest point of S wave is not over 100 milliseconds. The initial R is very small. It's a kind of QS pattern. This is a patient that we did study, and it was SVT with aberrant conduction with left bundle branch block. So if they doesn't fulfill, then SVT with aberration. Thank you. I think I'm going to stop here. Thank you.
Sir, it was wonderful. It was more of a session for people like us than for the students. We have learned so much.
Yeah.
We do give answers sometimes properly, but the thing is, how do we reach the answer? The way of reaching that is sometimes very important.
Sir,
And that you are teaching us very nicely.
hello, sir.
Yes. Yes.
Sir, but what is your suggestion, sir? Sir, there are different other algorithms.
Yeah.
So we should always practice the Brugada algorithm, sir. What is your suggestion regarding this, sir?
Well, I always believe in simple things. You know, there are many, I mean, I found a little article. There are literally many different criteria. I mean, it's impossible to remember all of those. So I think at least the reason I present this one is that these are simplistic way of remembering the common things. So I prefer this one. It's easy to remember, at least the bunch of criteria that concordance, AV dissociation, and the morphology criteria, right and left bundle. That really covers most of the cases that we do.
Thank you very much, sir, for your nice, elaborate, and exclusive presentation.
Sir, regarding the that is concordance, either positive concordance or negative concordance in case of the VT. That is the you just nicely described the mechanism, sir. Sir, is there any explanation regarding the exit point of the VT, sir? There is sometimes one exit point or the two exit points like this.
Yes, I mean that becomes a little complex. The question is, the VT can originate anywhere, but exit point decides where the site is. So it applies to fascicular VT. If the fascicular VT, how it exits, and that will determine. And that's important for ablation, because you may find a VT which you think is in one place. You may study, when you study that, you find that the mechanism is a little bit further away from that exact location. And that's more, this is more important during the ablation procedure.
Thank you, sir. So Professor Syed Nasiruddin is here, possibly, I think. Nasir, MG Azam. So today's talk was very, very excellent, sir. We want similar talks more, sir. Actually, this is the I think this should not be the final talk, sir. Regarding these topics, sir. We
Sure.
want to, sir, just the SVT versus VT like this, sir. Today's explanation like this.
Sure, we'll do that. Thank you.
Sir.
Sir, thank you very much, sir, for your presentation. It always helps us to develop our knowledge regarding simplistic approach for diagnosing an ECG and also management. And we hope that this is the second lecture of session 1, which focused on wide complex tachycardia SVT versus VT, and we will have the session 2 of this topic.
No,
Until then,
we do it actually. The first one I did a mechanism, so this will be the last one. We'll do again sometime in future, similar topic.
yes, sir. Because this was the lecture 2 of session 1, as you instructed us.
Sure.
So we hope the session 2 will focus more specific things regarding SVT and VT and wide
Sure.
complex tachycardia approach, and also management part.
Sure.
And our participants, again, we are thankful to all the participants who have participated for quite a long time with us, stayed with us, and we hope that they have enjoyed very much with the lecture from legendary teacher. And we are delighted that sir always gives us this sort of excellent lectures.
Thank you.
Wadud bhai.
আসলে আমি এটাই বলছিলাম যে আমরা তো আসলে যে ডায়াগনোসিস করবে করি, কিন্তু clarification of mind, knowing the basic principle of why we are saying that, why this thing occur, এই জিনিসটা স্যার কিন্তু আমাদেরকে শেখাচ্ছেন। আমার মনে হয় যে আমাদের জুনিয়ররা খুব লাকি, because they are going to learn it from the very early stage, so not at our advanced stage. So they are going to be much more better than us in interpreting ECG, in interpreting what to do and what proper advice the patient should be given. এই জিনিসটা তারা অনেক ভালো করবে, কারণ তারা প্রপার নার্চারিং হচ্ছে। থ্যাংক ইউ স্যার। এন্ড আসলে এটা সবাই মিলে যে এনজয় করা, সেটা একটা খুব বড় ব্যাপার। আজকে শুধু হাফিজ ভাইয়ের কোনো কথা শুনলাম না।
না, হাফিজ ভাই লন্ডনে আছে, যে কারণে আমাদের নেক্সট সেশনে স্পিকার হবেন কিন্তু হাফিজ ভাই। এরপরে কিন্তু আমরা স্যারের কাছ থেকে, আমার মনে হয় স্যার মোর বেসিক, পার্টিকুলারলি আজকে আমাদের কোশ্চেন সেশন থেকে মনে হলো যে উই শুড ডিসকাস অ্যাবাউট দা বান্ডিল বেসিক মেকানিজম এগেইন স্যার কিছুটা। আমার মনে হয় যে স্যারের কাছ থেকে আমরা পরবর্তীতে আবার বেসিকের আমাদের নেক্সট লেকচার স্পিকার হবেন হাফিজ ভাই, তারপরে আশা করি যে আমাদের স্যারের আবার একটা লেকচার শুনতে পারবেন।
ওকে, অলরাইট, থ্যাংক ইউ।
সামনে 26 তারিখ আবার আমাদের নেক্সট লেকচার সেশনটা হবে এই মাসের 26 তারিখ রাত 9:30টায়।
ওকে,
Thank you very much, sir.
thank you, bye-bye.
থ্যাংক ইউ।
Thank you all the participants and the physicians.
Good night, sir.
And also thank you our scientific partner, Dept Pharmaceuticals, for their continuous support in promoting this educational platform.
Thank you. Excellent session today.